Welcome back again. This is Lesson 4, Part 1, Hypertension. There will actually also be a Part 1A that you'll notice when you open your folder. Objectives are described here. We're going to focus on the cardiovascular drugs and take a look at cardiac risk reduction in various populations as our main focus in primary care. Of course, we have such a short time to learn about these drugs, and to become a specialist in cardiology would take several years, so we will be skimming only the surface and focus on this risk reduction. Our medications that we're going to focus on are listed here. Again, these are mostly the primary care kind of uses, and we will focus on an example from each of the drug classes. I'm going to start with hypertension, and the first question is why should we treat this problem? High blood pressure, of course, is very common, and as we age, it becomes more common. And the thing we have found out is that the consequences of hypertension lead to several target or end organ damages over time, and our goal in treating hypertension is to reduce the damage that can occur and thus reduce mortality and morbidity. First, of course, the cardiac system itself, the heart, its muscle itself, the left ventricle, can become enlarged simply by the matter of these pressures that cause the left heart to become enlarged and flabby, thus leading to some heart failure down the road, perhaps. In addition, stiffening of the the vessels that supply the heart muscle can lead to coronary heart disease. Similarly, in the renal system, in the kidneys, the damage to the vasculature there can cause the blood supply to the kidney to be compromised, as well as actual damage and pressures within the kidney. Keeping, of course, in mind, which we'll discuss later, that the kidney itself plays a key role in blood pressure homeostasis, keeping that balance in normal situations, and sometimes adding to hypertension. The peripheral vascular system, of course, is affected when the pressures over time from hypertension cause a narrowing of the arteries and arterioles or atherosclerotic changes. Similarly, in the back of the eye, the retina can be affected, and there can be damage there from both narrowing of those blood supply as well as bleeding from extra pressures. In the brain, again, similarly, we have loss of blood supply to areas and ischemia, causing transient ischemia attacks or TIAs, and those can also lead to a stroke, or on the converse, bleeding from excess pressures causing hemorrhagic stroke. When we think about how we're going to treat high blood pressure, we turn to the guidelines, and currently, and this was in our reading, the 2014 JNC 8 blood pressure guideline is what we use to guide our treatment. It's fairly straightforward, and it basically takes a look at two major populations and then divides them into age cohorts as well as racial cohorts. So the major populations become those who do not have known diabetes or chronic kidney disease versus those who do. And then within the folks who do not have known disease, treatments alternatives are lined out in terms of non-Black patients versus Black, and that's African Black. As we walk our way through the protocol, there are recommendations for starting agents and adding agents as we go, and of course including lifestyle changes. So this is a fairly busy slide, but I would say it's probably the most important part of that guideline to kind of keep in your hip pocket, and it will serve you well if you're going to work in a primary care setting over time. I'm going to take a bit of a step back and compare this JNC8 to JNC7, which preceded it, and not because you need to kind of memorize either one or the other or both, but just to understand that there was a prior version. Some folks are still referring to that, and there are some major things that happened that are quite different in thinking, and you may see these differences play out in primary care settings. First of all, the new guidelines tell us that as we age, of course our blood pressure goes up, and that trying to create strict control of blood pressure at advanced ages is not necessary. So at age 60, we start to have a different criteria for blood pressure management in the normal population. And we think about things like being very careful with our elders who actually suffer consequences from treatment which can outweigh the benefits of treatment, such as antihypertensive medications causing dizziness or low blood pressure, and thus falls, which carry with them huge impacts in terms of mortality and morbidity and function. We also see in this guideline that there is a consideration of the racial heritage in terms of recommendations, especially around the ACE inhibitors and ARBs, and we'll talk more about those drugs later, but just to understand that in certain populations, those drugs may not be as effective, therefore are not necessarily recommended as first line or second line. In this guideline, you will not see reference to stages of hypertension. You may hear that language out there or see it in research articles which have been published in the past years, looking at prehypertension, stage 1, stage 2, etc. The current thought is that that's not as important as to go ahead and choose a treatment strategy, get the blood pressure down to goal, and that using one drug at a time is okay, and that we don't need to try to move people through stages quickly necessarily by loading up a number of drugs all at once. I will add a caveat to that you want to keep on top of these folks fairly carefully, and that 2 to 4 weeks you might be adding agents, double checking, seeing where they're at with their pressure with the one agent, and then you're going to add different agents. There used to be a thought about compelling indications in terms of choosing drug categories, and this has been substituted with the concept that we have those who have chronic kidney disease or not, or those who have diabetes or not diabetic. Beta blockade is still low on the decision tree for a drug choice, but we do consider it for other indications, and we'll talk a little bit more about that later. So let's jump right into a case, so to speak. This is called the triple jump, where we're going to see 3 kind of unfoldings of his case. We'll start with this is the first jump. I'll let you read the materials in front of you, but basically this is Joe, and you'll see highlighted the issues that pop out of his history. First of all, he's had 3 or more readings of high blood pressure, therefore we're comfortable saying that he does have high blood pressure readings, and we don't think it's just a one-time thing. He even has a history of borderline high blood pressure in the past. His father did die of cardiac disease and died young. Therefore, we know he's at risk, has cardiovascular risk. He currently smokes, thus creating another risk, and he does drink alcohol. He has a stressful life as well, and I think a lot of us would kind of say, oh yes, that must raise their blood pressure. And we all know, both intuitively and even scientifically, that that is so. However, it's very hard to measure that, and therefore you will not see a lot of work out there in terms of guidelines telling us to take a look at stress or stress management, because we've just had trouble measuring it. It doesn't mean it's not real. He has some medications that I want you to pay attention to, especially the fact that he is on an NSAID, which is a nonsteroidal anti-inflammatory medication, buffered aspirin, which he uses for joint pain for his arthritis, which is probably an osteoarthritis. He also takes some Pepsin for heartburn. And then you'll see, of course, his physical examination revealing the blood pressure is elevated at this time. We also see some negative things in his exam, in other words, some normal findings that reassure us that at least at this point we can't see obvious evidence of end organ damage. The fundoscopic exam, the fundus looks good. The retina does not have any AV nicking or exudates. The heart has no S3 or S4 sounds or murmurs. So at this point, we want to think to ourselves, what's the working diagnosis and what's our differentials, just like we always are going to do in primary care. And you may say to me, why is that important and what difference does it make? He has high blood pressure, let's just treat it. Well, here we want to discriminate between what's called primary hypertension, which in older terminology is called essential hypertension, or is this a secondary hypertension caused by a different problem? And so in this case, we may explore some of the potentials for a secondary hypertension, but given that he has had hypertension for a long time, really, we understand that he is probably a primary hypertension. We then start to think of a best choice of drug. We want to think of, what's our rationale? Why would we choose it? Taking a look at the guideline. And then also do consider, what if he were black, and what would you do differently? So secondary hypertension, in most populations, adult populations, we are not highly suspicious. However, in some populations, we have a very high index of suspicion. First of all, in pediatrics, hypertension does occur in children, and we do that by percentiles, just like their height and weight. Older children, of course, their blood pressure goes up, and heavier children or obese children have high blood pressure. And this may not be necessarily something pathognomonic such as kidney disease, which is one of the things we look at first when we're thinking secondary hypertension in children is the kidneys. But the obese child may have an elevated blood pressure, which we simply try to treat by getting their weight down, while, of course, checking the kidneys to be sure they're functioning properly. And then look for other causes if we cannot see a change after the weight is lost. Also, in a new onset of hypertension in an elder, and they're talking really 60 and older here, that would be cause for some alarm. That doesn't mean the gradual creeping up. And if you have data over the years and see that there always was a pattern of escalation of blood pressures over time, that is not as much of a concern as the sudden drastic change of blood pressure that is occasionally seen with secondary problems. Now, secondary causes can be many. There are some of those that are intuitive, such as kidney disease, thyroid, and vascular disease, and some not so much, such as sleep apnea. And we're not going to really get into that here, but I just want you to understand that even in those cases where it may be a secondary hypertension, and there may be a cure, if you will, in some cases we are going to continue to treat the numbers, get the blood pressure down regardless of the cause, whether it's primary or secondary. So when we are prescribing, we're going to consider, of course, going back to our good old blood pressure equation: heart rate times stroke volume times peripheral resistance. And what that means is if any of these, it's like juggling balls in the air, if any of these is affected, the homeostasis or blood pressure control, which of course we need to keep blood moving around our body, is disturbed. And our drugs act by changing some of these. They may decrease the heart rate, therefore decrease the blood pressure. They may take out some volume, or they may relax the peripheral resistance. So we also want to think about what kind of cautions we might have for this patient. What are the monitoring considerations that we have? Is this a person who has, say, liver disease, that we have to be careful of drugs that are metabolized by the liver? Are they a patient for whom we'll need to watch, or the drug may cause us to need to watch certain laboratory studies, and we'll talk about that a little bit later too. We also want to think about common and worrisome side effects and adverse reactions. I like to separate those two, although often side effect and adverse reactions are listed in the same list in our Hippocrates. But common and worrisome side effects may be things that the patient is bothered by, and adverse reactions may be things that we're bothered by, such as anaphylaxis. Non-pharm treatment, of course, is very important as we seek to get and maintain good